All right. So our last two topics, and they're related to each other. They're basically extensions of each other. In the vascular section is pulmonary hypertension and cor pulmonale. So pulmonary hypertension is exactly what it sounds like. It is elevated blood pressure in the arterial side of the pulmonary vasculature. So if you think about it, this. I know this sounds a little backwards. Everyone associates arterial blood flow with the aorta, but in this case, the pulmonary artery blood flow is pulmonary artery. It's blood flow that comes from the right ventricle going into the lungs. So as previously in the pulmonary embolism discussion, we were talking about clots that move from the veins into the right atrium, into the right ventricle, and then into the pulmonary arteries and pulmonary capillaries. Pulmonary hypertension is the only way it's related to that really is that it is the pulmonary artery side. It is that side of the heart that puts pressure or that the right ventricle experiences the pressure of. So let me try to simplify this for you. Systolic blood pressure is the blood pressure that the left ventricle experiences. So your left ventricle, when it squeezes, it produces or experiences, however you like to think about that, left ventricle creates a pressure of 120/80. That is your systemic blood pressure. The right ventricle is squeezing at the same time, but it's pushing blood into the arterial blood flow. So there is an arterial pressure. It's usually in the range of, like, say, 25/15. That would be approximately normal for the pulmonary artery pressures. But those pulmonary artery pressures are the blood pressures for the the right ventricle. The right ventricle experiences blood pressure in pulmonary artery pressures. The left ventricle in systemic blood pressures. So now we're talking about the blood pressure from the right ventricle, or that the right ventricle encounters. And more than not, when we're talking about pulmonary hypertension, we're talking about a pressure that's a result of some kind of problem with the lung that has increased the work of the right ventricle. So hypertension is hypertension. It's high blood pressures. In this case, it's high blood pressures in the pulmonary circulation. All right. Now, if you think about that from a very superficial level, it would make sense that there's got to be some kind of condition that affects the lungs that creates that increase in pressure. And we're going to talk about how those evolve here as we move through this conversation. Now, as pulmonary hypertension worsens and becomes more severe, it progresses into a condition called cor pulmonale, and we will elaborate that as we go further. So let's start walking into this. Commonly, pulmonary hypertension is not a condition that someone just figures out that they have. For example, we've talked about asthma. As a contrast, people can have some experiences where they have trouble breathing, have trouble getting air in, they notice wheezes, they go to the doctor and they talk with the doctor. He listens to them, looks at what they've said, and is able to make a diagnosis. I think you've got asthma. We could do peak flow pulmonary function studies to confirm that, pulmonary function tests. However, that diagnosis could be made clinically that way. That doesn't happen with pulmonary hypertension. People commonly do not have symptoms that they say, oh, I think I've got pulmonary hypertension, and go to a doctor, and the doctor in conversation say, you have pulmonary hypertension. Most commonly, pulmonary hypertension results from another condition. A common contributor to pulmonary hypertension is chronic obstructive pulmonary diseases. So that is a common contributor. Another big contributor is a condition called pulmonary fibrosis, which we talked about. So these chronic lung conditions are the biggest contributor to pulmonary hypertension. Now, the way we commonly find out someone has pulmonary hypertension is a scenario like this. A patient comes in and they have some shortness of breath. Come to the hospital, it's bad enough that they need to be at the hospital. And we determined that this is an exacerbation of their COPD. And perhaps when they come in the process of all this, they're having shortness of breath and they also experience some chest discomfort. So as a process, we can't, let's say we get an EKG and we can't completely rule out that they don't have heart disease. Maybe they're in a risk category that stratifies them for potentially having heart disease. So we take them to the cath lab. We go back to the cath lab. We've gotten their COPD stabilized so they can be in the cath lab. And when the doctor injects dye and starts measuring pressures in the right side of the heart, in the right atria, right ventricle, and pulmonary arteries, then he sees these elevated pressures. And we say, holy cow, you've got pulmonary hypertension. That would be one scenario. Another scenario would be that the patient commonly, is having problems, and as an outpatient, and a physician says, well, we should probably send you over to a cardiologist and have them evaluate you. And, in the process of doing that, they might order an echo, or the physician might even order one as a way to be prepared when the patient gets there. So this echocardiogram gets performed, and when it's read, the cardiologist who's reading the echocardiogram can see the pulmonary artery, an estimation of the pulmonary artery pressures done by sonogram, and have evidence that we think you've got pulmonary hypertension. Patient never thought they had it, their issues were about something else, and they've had this echocardiogram, and here we go. So it's often discovered secondarily to other conditions. So this is not something that's people are raising a red flag about and discovering they have pulmonary hypertension. Common, and as a general rule, in order to, even if it's found as an outpatient, to confirm that diagnosis of pulmonary hypertension, they need to go to the cath lab and have a right heart cath to measure those pressures and confirm that. Just to rule out that there aren't any other kind of mimics that are creating something that looks like hypertension, pulmonary hypertension in these patients. There are 5 major classifications, and I have them listed here for you. Primary pulmonary artery hypertension. What primary pulmonary artery hypertension is elevated pulmonary artery pressures that have no other cause. So the patient doesn't have heart disease, they haven't had lung disease, they haven't had a pulmonary embolus, they haven't had a multifactorial condition such as a motor vehicle accident and a stroke and a complicated medical history. So in other words, there's no cause. That's referred to as primary pulmonary hypertension. Now, left heart disease, because left heart disease can put such a strain on the lungs and subsequently create a backflow and a back pressure into the pulmonary capillary bed, that can produce pulmonary hypertension. So we can have pulmonary hypertension as a result of conditions such as left ventricular hypertrophy, a myocardial infarction that's led to protracted heart failure. All of those things could potentially contribute to the development of pulmonary hypertension. Also, lung disease. I've mentioned some already, such as COPD and pulmonary fibrosis. Those conditions can produce a resistance that the right heart is having to push against. When that right ventricle is trying to push against this change in lung structure, then that can produce pulmonary hypertension, and when it's severe enough, ultimately cor pulmonale, which is a lung problem that produces a coronary problem. So pulmonale is the Latin reference to the pulmonary system, and cor, the Latin reference to cardiology or heart. So that is a heart problem as a result of a lung problem is what cor pulmonale is, and we're pushing toward right heart failure as a result of this lung condition. That's what's meant by cor pulmonale. A pulmonary embolus can do this. You could see, we talked earlier about massive pulmonary emboli. When you have massive pulmonary emboli, you have big occlusions in the pulmonary capillary bed. So this right heart is trying to push against occlusions that can produce pulmonary hypertension. And then, of course, multifactorial conditions, when you have patients who have several things gone wrong. For example, a patient who's been in a motor vehicle accident and has had a flail chest and has had pulmonary contusions and has also had pneumonia, along with other fractures and complicating conditions and perhaps surgery to address some issues. You can see where those multifactorial conditions could potentially be compounding a pulmonary hypertension or produce a pulmonary hypertension. So how are we going to assess this? I mentioned echocardiography, and echocardiogram is one way that we can evaluate pulmonary hypertension. It's not 100% diagnostic. Again, we need a right heart cath to measure those pressures and know what those pressures look like, but an echo can give us evidence that supports a diagnosis of pulmonary hypertension. It also allows us ongoing, once we have the diagnosis, it allows us to manage or monitor, I should say, the right ventricle and how well we're doing with managing pulmonary hypertension. Theoretically, if we can address it with a medication and improve that pulmonary hypertension, if it's early enough, we may eventually see some remodeling of that right ventricle and it reforming to its original shape, not maintaining a thickened or enlarged right ventricle. That's what we would hope for. A 12-lead EKG can show us a couple of things that would be indicative of, not diagnostic of, but indicative of right heart failure and pulmonary hypertension, and that would be right ventricular hypertrophy. This has to do with the amplitude of the waves in a certain region of the 12-lead EKG. I'm not going to get into great detail about that. Also a condition called right axis deviation, which again from a 12-lead EKG shows us that we have enlargement of the right ventricle and the electrical activity is moving that direction. So that would be stuff that's indicative but not diagnostic. Physical examination, you notice there are a lot of maybes here. Maybe weakness, maybe hemoptysis, maybe distended neck veins, maybe crackles, maybe hepatic enlargement. All of those things are possible. They may have them, they may not. Obviously, it's going to depend on the degree and the progression of pulmonary hypertension. In more severe cases, you're going to see more of these things. So more severe cases, you'll see hemoptysis. You may see hemoptysis in someone with pulmonary hypertension because they're having a pulmonary embolus. Remember, that can be a symptom of pulmonary embolus. So you can see how these symptoms can begin to interweave and overlap. Distended neck veins, because of that resultant high pressure in the right ventricle, if it's having trouble moving into the pulmonary capillaries, it may be inclined to back up and create distension in the neck veins. So those things can happen. Now, as this progresses, as this moves along in severity and moves toward cor pulmonale, this fluid from right heart failure is going to have to back up somewhere. And the places where it can back up are obviously in the neck veins, but gravity is going to have a huge effect here. So there's going to be more accumulation in areas lower in the body, such as the abdomen and the periphery, specifically hands and feet, more feet than hands. But in the abdomen, yes, we see distension, perhaps distension of the abdomen, but more concerningly, things happen to the mesenteric and splanchic bed that produce hepatic engorgement and other forms of edema around organs, which can produce things like ileus and other forms of organ dysfunction, verging on liver failure and other problems. So there are definitely complications of this edema accumulating around things like liver, kidney, intestines, stomach, and then in the periphery because it doesn't have anywhere to go. So obviously, management of pulmonary hypertension is going to depend on the severity, and that severity is going to guide the treatment. So oxygen will be a component of this as a as a relative to how much oxygenation issue they're having. So we're going to go cautiously with oxygen here because some of the patients that have pulmonary hypertension as a result of chronic lung disease may have things like emphysema and other conditions where we may not necessarily want to drive high SpO2s. So the oxygen, yes, but we want to be cautious and judicious with how we use oxygen for these patients, depending on the cause, the ultimate origin of their pulmonary hypertension. Prostanoids are going to be one of the staples of treatment. So these are things like epoprotenol and treprotenol and iloprost. These drugs are continuous infusions that are provided that are drugs that specifically address pulmonary hypertension. So those drugs, again, usually administered in the hospital, commonly administered in an intensive care unit. At some point, there is titration of these medications to get optimal pulmonary hypertension, pulmonary artery pressures without getting hypotension, because that is a potential side effect of these drugs. They can definitely do that. So you can see these drugs are related to the prostate type of enzymes that are secreted in the body. You will also see drugs like bosentan, a endothelin relaxin factor. Those help the endothelium relax, which is attempting to be a more specific type of antihypertensive in this case to treat pulmonary hypertension. And then, of course, the phosphodiesterase inhibitors. So you'll notice right here, this first drug, sildenafil, you know this drug by a different name and for a different treatment, but this drug was developed for the treatment. This is Viagra, was developed for the management and treatment of pulmonary hypertension. That's its original intention. And then patients who had taken this drug as a part of the investigation noticed a beneficial side effect for them, and so it found another place in the whole marketing structure. And other drugs came along. Again, you have to there's a twofold thing. Of course, pharmaceutical companies look for a way to perpetuate their business and their science. So I'm not trying to raise skepticism here, because they are trying to be beneficial to mankind. But they also look for ways to keep their doors open. So they wanted to advance this. Sildenafil had a greater effect in other areas, increasing blood flow. So let's see if we can refine drugs to make a better one, more for the pulmonary vasculature. So that's where tadalafil and vardenafil come onto the market. And obviously, other companies may want to get into this side hustle, if you will, for that sildenafil created. So those are drugs you will see out there. The beauty of these drugs is they're taken orally, so they can be easily administered. There's no tests, no titrations that have to be done. Maybe some drug adjustments over time based on symptom and function, in life. So these are drugs that patients can be started on as a way to manage their pulmonary hypertension after they've been brought under control with the IV infusions like the prostanoids or perhaps the endothelin relaxin factors. So we can get them under control, get them managed, and then send them home on these drugs because they can be taken at home. They're outpatient medications. And if this pulmonary hypertension progresses and continues, then transplantation is, of course, consideration. And obviously that's going to depend on transplantation is multifactorial. There are many factors that go into decisions about transplantation: age, overall health, the cause of the pulmonary hypertension, the compliance of the patient, obviously organ compatibility from donor to patient, many factors that go into transplantation. So that can definitely be a consideration. So this concludes our section on the vascular aspects of pleural pulmonary conditions. Next section, we're going to be picking up with infections and touching some into environment and occupation. So we'll spend most of our time from here on infection-related pulmonary issues.